All right, thank you. My name is Nick Caruso, and this is a presentation on artificial intelligence for oncology. Let's see. All right, and this is based on a journal article called Artificial Intelligence for Clinical Oncology by Dr. Benjamin Can out of Harvard and Mass General. Like Dr. Steiger just said, I'm a third year at KCU with interests in hem-onc and translational research. The reason I wanted to make this presentation is when I was on my hem-onc rotation and talking with other physicians, they have a lot of concerns for the role of artificial intelligence in the future, and that it could replace jobs, but also there's a lot of praise for it, and that it could be a very useful tool that can help us treat people better. And I also have friends in the tech world that like to use Chat GPT and are doing their best to get themselves a self-driving Tesla. So I think it's a really interesting area that will touch all aspects of our life. So the idea of artificial intelligence started around the 1950s, where machines are able to utilize data and perform tasks without explicit programming. And then later that developed in something called machine learning. And that's a lot of different areas of math and computer science, and one being logistic regression, where we label variables and then you input it into an algorithm or computer program and it becomes weighted. And deep learning is kind of the colloquial term, or deep learning is the more specific term for what we colloquially refer to as artificial intelligence. And also in the literature, when we talk about artificial intelligence, we're really talking about deep learning. And deep learning is and are layered neural networks that allow you to put in raw, unstructured data and then come out with an end result. And this might be putting in radiology, biometric data, unstructured text in order to produce a diagnosis. And you're able to do that without really, the computer does all the work. You don't have to tell it, this is radiology, this is biometric data, like we previously would have with machine learning. So deep learning is what we're generally talking about with artificial intelligence. And currently, we're seeing a renaissance of AI or deep learning in tech. We have Chat GPT, where you can put in a question and get out an essay or whatever you need. You can really come up with a lot of things. And all of our social media feeds utilize AI in order to give us that constant feed of dopamine that keeps us scrolling, like on TikTok, and also with Tesla and self-driving cars. One advantage that big tech has that we don't in medicine is that big tech produces billions of data points every second, and they're able to feed that into deep learning programs and come up with really great products like self-driving cars. And we need AI in medicine because it's a new tool to use. With cancer incidence increasing globally every year, there's an incentive to provide value to that area. And value in medicine is decreased morbidity, mortality, and costs, just providing efficient and quality healthcare. AI in medicine is not going to be a one-size-fits-all answer. I think a lot of misconception with talking to my preceptors and a lot of people is that AI is going to be this one-stop black box tool that you can put in data about a patient and come out with, a year's worth of prognosis and diagnosis and treatment. But that isn't what it's going to be. AI is going to be a tool, and it's currently at a very young age. And when we use it, it's going to be at these very narrow task-specific touch points that are clinically validated. And clinical validation is important because everything we use in medicine has been clinically validated and tested. So an issue with data or in medicine is that in the past, or I guess not an issue, but in the past with data, it's always had to be human digestible and concrete, One example is the TNM staging or categorization of cancers. So with that, you would label a cancer based off size, lymph nodes, and metastasis. And from that, you could get a prognosis and develop a treatment plan. And that's using things like size, lymph nodes, and metastases that us humans are able to picture. But with AI, it's going to integrate disparate data. So data that we just don't really understand, whether it's like the minute-to-minute cardiac output of a patient. And so AI can offer a unique perspective on data, and that's constantly changing. And but with AI and medicine, we have a big problem because we're not TikTok and we're not Google driving around with cars with the cameras on them. There really isn't very much data, relatively speaking, when it comes to medicine. And especially when you think about cancer, there's even less, because with cancer, you can have a melanoma, a basal cell carcinoma, which is skin cancer, chronic myeloid leukemia, acute myeloid leukemia. And within these, there's different mutations that makes every cancer unique and hard to develop data on. And also medical data is generally private and fragmented between health systems. But as patients move along the cancer care pathway, you create more and more data about them. So you start with a TNM staging, and then you get genomics, and you have tons more data as you get to know a cancer patient. And current ways we record this data is the electronic health record, the cancer genome atlas, cancer imaging archive, and Project Genie. And these have histopathology data, qualitative, quantitative data imaging, and various other aspects of data like tumor genomics. And so in the past, we've tried to create this one-stop shop for oncology, and that where you just put in the patient about data and expect like a year's worth of prognosis and treatment expectations. And that was called the IBM Watson Oncology Project. And it unfortunately failed, which I think is a little bit to be expected. There's no other aspect of medicine where we just have this huge, one-stop shop. It's a bunch of people collaborating and figuring things out. And a bunch of tests that are perform a narrow task. If you think of something like rheumatoid factor, that's one blood test that goes into diagnosing rheumatoid arthritis. So with AI, it's going to be narrow tasks with high reliability, and that requires validity, utility, and usability. And we'll be able to utilize AI at clinical touch points. And this is where we can have patient and clinician decision-oriented points of contact to make decisions that will benefit the patient. And you can improve these decisions with AI. And several points that the authors of this study believe we'll be using AI, and what I'll talk about next are prevention, screening, diagnosis, staging, treatment, response, and follow-up. And here's another list of them. And so when we're talking about risk prediction and prevention, and these are all studies that have been published on how we're using artificial intelligence or deep learning. You can use deep learning satellite imaging data to predict the risk of cancer. And it does that because geographic data is related to socioeconomic status, obesity, and alcohol use are a few criteria that help it predict cancer risk along with satellite data. And even internet search history. And in this study, a patient in January was searching for bloody cough, and then later would Google, in June, I was diagnosed with lung cancer. And based on that, you can utilize internet search history to predict someone's risk of cancer. And there's also a Bodacia breast cancer risk assessment, which is based on a Switzerland study with 112,000 individuals. And when we use the current Bodacia risk assessment tool, you have an accuracy of about 64%, but when you apply machine learning, that accuracy increases to 85%. And screening is an area that I think AI has a lot of potential for. I think currently we screen for lung cancer and breast cancer are two big areas where we do screening. But in the future, when we're able to combine multiple different serum markers such as PSA, and then we'll be able to screen for different cancers. And we have been able to kind of start to screen for prostate cancer using artificial intelligence with PSA, which is prostate surface antigen, which is secreted by the prostate and increased in prostate cancer by combining it with white blood cell count and prostate volume. And also, I think screening is an important aspect because it's a huge area of healthcare expenditure. On this graph here, it's projected in 2024, we'll spend $1.8 billion on screening for lung cancer. And so to talk a little bit about mammograms, mammograms are a narrow task. They're a radiology test women over 40 receive every 1 to 2 years. About 68% of American females who qualified for it received it last year. And then ultimately you diagnose breast cancer via biopsy. So the way I see incorporating AI is AI can read the mammogram with a very specific task-related purpose. And then it ultimately will have to be biopsied, so we're not completely relying on AI for diagnosis. And also, in 2020, the United States healthcare spending was $600 million, and the global market for mammography was $2.1 billion. So there is a lot of financial pressure to be able to have a computer program to do this, which would just be cheaper than a fellowship-trained radiologist. So I think that's a very exciting area. And other aspects that AI is being used is in diagnosis. With skincare utilizing digital photographs, AI can produce dermatologist-level diagnoses. And maybe a new area that we're not able to use yet is creating histopathologic data to predict the underlying genomic classifications in glioma. So with that, you would take a slide of the glioma, and it would be able to tell you what genetic alterations have happened to the cell, instead of maybe running it through a PCR, to find out the genomic changes. And with risk stratification and prognosis, historically, we've used the TNM staging like I discussed earlier. And with breast cancer, we use something called an oncotype, which uses logistic regression machine learning, kind of that step above or prior to deep learning, and the Decipher scores for prostate, which uses a random forest classifier. And like I discussed earlier, using disparate data that we as humans don't really know how to use. One study utilized 127 variables to create a prognosis for non-small cell lung cancer. And also we can utilize electronic health record data to predict 180-day mortality. And initial treatment strategy. So this is something that oncologists are specialists in. They utilize TNM staging, the oncotype. But one area where we're not super great at understanding, I guess the effects of treatment is immunotherapy. It's difficult to predict. But when one study used radionomic data, radiology, to predict a cancer's response to anti-PD-1 or anti-PD-L1 cancer treatment, which is immunotherapy. And what they use solid tumor CT images and RNA genomics. And also another area that we haven't been able to use yet is using the histopathology, like this pathology image here, And with it, you can have a better idea of the vasculature and white blood cell population. And those are two areas that affect the ability of immunotherapy to treat a cancer, because it needs the vasculature to get there, and white blood cells can produce cytokines that make immunotherapy feasible or not. And response assessment. Currently, we use radiographic and clinical assessment to determine how well chemotherapy is working on a patient. We use tools called the RECIST criteria, or RANO. On the right here, I have a digestible version of the RECIST criteria. It classifies tumors as complete response, partial response, or stable disease and progressive disease to chemotherapy. And this has worked okay in the past. It works well, it cures some cancers, but it's very time intensive. And using this criteria, there's high intra and inter-reader variability. And also, once again, when we're talking about immunotherapy, immunotherapy has a phenomenon called pseudo-progression, where the cancer appears to be progressing, but is actually heading towards remission. And if we apply AI to these areas, we can have a better idea of how the patient's doing. And subsequent treatment strategy. Once again, after an initial round of chemotherapy that isn't responsive, we're dealing with an even smaller patient population with a smaller amount of data. Because now you have this patient who's gone through the litany of cancer tests, but they're not responding right. And so that's an area that we could use AI to parse through that data and get a better idea than what we currently have. And also, we can use radiology to look at how to predict the recurrence of lung cancer. And if we looked at the cancer, the lung cancer, and thought it's going to come back, you would do something called consolidative treatment, where you continue to treat the patient for cancer to increase the chances of remission. And follow-up. So follow-up, every doctor's visit is an expensive process. If we use AI to triage patients, we can know, oh, we only need to see this patient in a year, whereas we need to see this patient in a month. And that can help decrease healthcare costs. And by using electronic health data, one study has been able to categorize patients at high risk for an acute care visit, such as hospitalization or an emergency department visit. And if we thought they were high risk, we would increase their follow-up with a provider. And this scenario is biweekly visits. And then also on the more human side of AI and patient care, you can triage a patient and figure out if they have a high risk of mortality. And when they do, and if they do have a high risk of mortality, the AI program would inform the physician, and that should urge them to discuss values, wishes, and quality of life options. And having these tough discussions with patients increases a patient's mood and end-of-life care and ability to accept death. And all of these studies are great. They're all ways that we can move forward with AI, and there's been thousands of studies, but there's only 20 FDA-approved imaging modalities utilizing AI, and those focus on the thoracic, which is lungs and liver, breast, prostate, and CNS. And there have only been 9 prospective studies and 2 randomized clinical trials of deep learning and medical imaging. And most of these studies have minimal evidence for clinical impact, because we're not looking for that yet in the studies, which I think we have to realize. It's great to be able to use AI, but we need to be making a clinical impact, or else it's not value-based care. We're not getting anything out of using AI. And so in order for something to be translated clinically, it needs validity, utility, and usability. So clinical validity is the bare minimum. We need to make sure these tests work. typically you would do internal validation, external validation, prospective testing, and then doing it in a small local population. Very few AI reports utilize an external validation set, which reading that kind of blew my mind, because I just, if we're not testing on data outside of our own, there's really no utility to these tools that we're developing. And to be fair, and I don't mean to put AI researchers in the hot seat like Mark Zuckerberg has been in front of Congress. AI is this novel algorithm that is always changing, and now we're expecting an algorithm to perform patient care, and we need new guidelines in order to test this. This is a very new thing, and there are efforts with the FAIR data and consort guidelines to create better ways to test the validity of AI. And efficiency in diagnostics would be sensitivity and specificity. Once again, hammering home the point that these tests have to work. And it's not only important to make sure the tests can be accurate, but they have to result in clinical endpoints. They have to create changes for disease control, which would be overall survival or toxicity reduction, quality of life improvement, and cost effectiveness. It would be great if we could give everyone in the world the best healthcare possible, but that's not a reality. And the goal of AI is to decrease, would be to decrease healthcare resource utilization. We need to spend less money, as always. Continue on. And practicality. There has to be clinical usability. Physicians and patients have to be able to interact. It can't be some complicated computer program that no one can use. And AI is a bit of a black box. It's this algorithm that we don't program, it programs itself. And we have to ask ourselves, is that an acceptable form of diagnosis or treatment that we use in healthcare, using something we don't totally understand? And that's almost a little inherent when we're talking about deep learning. And of course, there has to be ways to judge user satisfaction of AI. And so in conclusion, I think the use of AI or deep learning in medicine is through specific touch points with narrow tasks and high reliability. This will happen with prevention, screening, diagnosis, and follow-up. I think two areas that we should really be focusing on are the yearly mammogram and lung CT for cancer, because of the amount of money that we're using for these screening tests and the amount of value we could get out of it. Immunotherapy is this kind of difficult to gauge form of cancer treatment that could be improved using pathology and AI. And of course, all of these utilizations will only matter if they have clinical validity, utility, and usability. Here are my references. Thank you. Are there any questions?
Thank you so much, student Dr. Caruso. I have a comment. AI is just so new, and I believe we're all right now trying to figure out how best to use it in our respective disciplines. It's clearly going to change the practice of medicine. And I heard a practitioner, of which I'm not, I'm a biochemist, molecular biologist, PhD guy, but I heard a clinician say this, and I wondered if you had any thoughts on this statement. He said, AI is going to be great to diagnose the zebras. In other words, the very rare cases that you don't see that might be misdiagnosed otherwise. Do you have any thoughts about that statement?
I think it would be the complete opposite. Actually, I think AI is going to be more for the bread and butter stuff, because of the amount of data that we have on the bread and butter stuff. There just isn't enough data on the 1 in 1 million diagnosis. And it's not something I touched about in my presentation today, but something the paper when this is over talks about, is that there's a lot of edge cases in medicine, the zebras, or maybe it's the prostate cancer that isn't behaving well, that AI is really not good at diagnosing or treating.
You have any hope that it will get better?
Of course, yes. I think in 50 years, we're going to be astounded at what medicine has turned into because of AI.
It's a brave new world. Dr. Gordon, go ahead.
Thank you. Excellent presentation. Thank you very much. Very interesting, obviously, very timely topic. And I'm segueing off of the previous question. So given, and I agree with you on your answer, by the way. So given what you said, my question is about implementation. How would you find this to be, because you mentioned using the electronic health record, how would you envision this to be the most useful? Would you think that it would be individual hospitals or ambulatory care centers' health records, or cancer centers' health records, or oncologist office health records? Or do you envision it some other way? Because I think we're very disjointed currently in spite of efforts to create a more connectedness between electronic health records. So what do you propose, or what do you think would be ideal about that?
Yeah, I think hopefully the goal is that AI can reduce healthcare costs, and then with that, there might be, and if you improve costs, there's going to be incentives for businesses like Cerner or Epic to incorporate it into the EHR. And I also think that residency programs should be pushing it. And when there is an AI program that is clinically useful, that it's spread, that physicians take the initiative to bring it into their hospital. I know currently when you use something like oncotyping, it's a test that the oncologist sends out for, and that would be, with AI, you would, instead of sending it to the oncotype company, you send it to the AI company, and they send back the results. And maybe it's as easy as doing it on your computer.
I think it would be on your computer, but I guess my question is, where does the data come from?
Oh,
So garbage in, garbage out. If you're in, I mean, I don't want to belittle anything because we live in Joplin, but if you're in a rural area with a limited patient base and you don't see sufficient cases of that, is that going to be helpful with that amount of data you have versus being in a major urban area with, a major hospital like MD Anderson, for example, that probably has hundreds of thousands of even the rare cases?
yeah. I think it should be accessible for everyone, because MD Anderson isn't going to have its own AI program in the rural Joplin hospital. All their data should be going to one algorithm or one computer program. So the MD Anderson guy and the Joplin gal can both utilize the same tool.
But how does that get created, I guess is my question. Where does it come from?
It comes from research creating a program, and then I think a company taking that program to market.
Google.
I agree with you. And so here's my prognostication: economics of medicine. I think it's going to be the insurance companies, because we all can't afford it. And so they want to know what's the most efficient treatment or diagnostic, and which tests are the ones they want to pay for. I think they're going to be the ones driving the industry to move that forward.
Yeah, and that's a conversation I had with a classmate, because if you think about a fellowship trained radiologist reading mammograms, I'm not exactly sure about their speed, but an AI program could do 100 in a second or a minute, just way faster than we ever could.
True. Thank you. Excellent. Again, very love your topic.
Thank you.
I'll yield to Dr. Johnston.
Thought-provoking, thought-provoking. What if it's Google that owns everything in the future? Dr. J, go ahead.
Gonna be Walmart.
Tag on to Dr. Gordon's commentary because I think she's spot on with regard to the follow the money. And with that, I couldn't help, first of all, Nicholas, I appreciate your presentations. It's high quality and very informative, so I appreciate it. There's a couple slides though that kind of stick with you, and there's some commentary at the end of some of these slides, and it's one that's still showing on my screen of questionable clinical validity, utility, usability. And you had stated minimal evidence to support the value, so to speak, of clinical care. So my question, Nick, is that we still don't have it. We're right at the tip of the iceberg, I'm sure. And where do you see, and Dr. Gordon may be spot on, is this going to be worth all of the money and time, energy, and people power to put into this, rather than looking at the utility of the outcome? Is this going to change management? Is this going to alter mortality?
My hope is that it can improve mortality and improve outcomes. And I think, yeah, when we're talking about things like immunotherapy and the tumor microenvironment, I think utilizing AI with pathology can give us a better idea of the tumor microenvironment, and which can help us develop better immunotherapies for specific types of cancers and ultimately improve mortality for these cases that we can't cure yet.
But we're not there yet. Yeah,
Not there yet.
thank you, sir.
Okay, do I see any more questions? Not? Thank you again, students. What a fantastic session. Looking forward to next week. Very quickly, let me drop into the chat the ever-changing schedule. If I can find Mr. Chat. Love having 4 screens. Here we go. That has been updated most recently and will likely change in the future. But this is an archive of everything that has gone before. And if there's something that you missed that you want to watch, you can find it here. And student doctors who presented today, I'll process the video as soon as Zoom provides it to me and then give you the links. You march forward bravely into the future. Student doctors Caruso and Wells, thank you again.
Thank you.
Thank everybody for attending. Have a
Thank
great
you.
rest of your day. Bye-bye now.